Dr. Girish, Dr. Ritu Chaudhary. I also take the opportunity to invite my president, Dr. Alithya Barboza, to come and join us, and Dr. Nikhil Kamath, Secretary of GOA. Although we've started a little late, I think this is the first time we are getting this opportunity to present, and we have only 3 speakers, so we won't bore you too much. We would like to first start by introducing Dr. Ritu Chaudhary, my senior colleague, specialist in cornea, refractive and glaucoma. She's an alumnus of KEM and Sion Hospital and did a fellowship at University of Kentucky in the United States, and then worked at Shroff Hospital for more than 18 years. Now she's happily settled in Goa, and we're happy to have her. Dr. Ritu, please start with your talk first.
Thank you. Good afternoon, everybody. I welcome you all to this session of Goa Ophthalmological Association at the AIOS. My talk for today will be glaucoma progression at controlled IOP, what to do. Glaucoma is a chronic progressive optic neuropathy causing retinal ganglion cell death, leading to visual field loss and permanent irreversible blindness. The only modifiable risk factor is increased intraocular pressure, so the treatment is based on IOP reduction to a level where no additional damage takes place. That's the target IOP. Now, we all must have had a patient in our clinic sometime or the other where the IOP is under control, we've reached target intraocular pressure, the patient is compliant, he keeps coming back for regular follow-ups as advised by us, but for some reason we find that the visual fields are worsening and the patient is deteriorating and the glaucoma seems to be progressing. So the question now here is, can glaucoma progress when the IOP is well controlled? Now, for the next 20 minutes, I'm going to walk you through some of what are the other factors other than IOP that we need to look into, and what are we going to do next for this patient. We need to think beyond intraocular pressure. A detailed history is a must. A good clinical evaluation is also a must, and we need to subject this patient to a detailed systemic evaluation as well. We know that POAG is secondary to optic nerve head hypoperfusion as well as autonomic dysfunction. The early manifest glaucoma trial was one of the first RCTs with an untreated control arm, which showed considerable benefits of treatment, which significantly delayed progression. But 45% of patients of the treated group who had an IOP reduction of 25% still showed progression. In the EMGT trial, the treatment reduced the progression risk by half, almost 50%, and the progression risk factors were found to be higher baseline IOP, pseudoexfoliation, bilateral disease, a worse mean deviation on the perimetry, older age group, and those patients who came back with frequent disc hemorrhages. Also, lower systolic blood pressure, lower systolic perfusion pressure, and cardiovascular disease were found to be new predictors for glaucoma progression, suggesting a vascular role. Also, a thinner central corneal thickness was another new factor that was identified. The OAT study, which is the ocular hypertension treatment study, showed that a higher baseline age, a larger vertical cup disc ratio, a worse pattern standard deviation on the fields, and a higher baseline intraocular pressure, these were good predictors for the onset of POAG. And a thinner CCT, less than that of 555 microns, had a 3-fold risk of POAG compared to those with thicker CCTs. In the collaborative normal tension glaucoma study, 12% of the treated eyes still showed progression in spite of an IOP reduction by 30%. So all this brought us to a conclusion that there are factors independent from IOP leading to progression in normal tension glaucomas. And in this study, the risk factors for progression were identified to be the female sex, those with history of migraine, and those with recurrent disc hemorrhages. So a summary of some of the landmark clinical trials. As you can see here in the OATS study, with a 20% IOP reduction, the treated group 4.5% still progressed. In the EMGT, in spite of a 25% IOP reduction, the 45% of the treated group showed progression. And in the CNTGS study, in spite of a 30% IOP reduction, 18% of the treated group still showed progression. So that brings us to the vascular risk factors. Low blood pressure fluctuations, nocturnal hypotension, low ocular perfusion pressure, and also large diurnal fluctuations were identified to be important vascular risk factors. Now, what is ocular perfusion pressure? It is the difference between IOP and systemic blood pressure. The ocular perfusion pressure was found to be more sensitive to change in blood pressure than to changes in intraocular pressure. So those patients who showed nocturnal hypotension, what we call as the nocturnal dippers, they were found to be progressing at a much faster rate. And a low ocular perfusion pressure of less than 55 showed an increased prevalence and was identified to be an independent risk factor for glaucoma progression. A low diastolic BP, that also causes optic disc hypoperfusion and glaucoma progression. And in the early manifest glaucoma trial and other studies showed that a low diastolic BP would cause a decrease in the perfusion of the optic nerve head and was a risk factor for glaucoma progression. Also, the low diastolic ocular perfusion pressure in the Baltimore eye study, I survey the patients with a diastolic ocular perfusion pressure less than 30 had a 6-fold risk of glaucoma progression. And also in the Barbados eye study and in the Los Angeles Latino eye study, the low diastolic ocular perfusion pressure was found to be an independent risk factor for glaucoma progression. Also, the mean ocular perfusion pressure, if that's on the lower side, then in the Barbados eye study, it revealed that that could be a risk factor for progression. Large diurnal fluctuations were also associated with glaucoma progression, and in the advanced glaucoma interventional study, it revealed long-term IOP fluctuations to be an independent and stronger predictor of visual field progression as compared to even mean IOP. So just to summarize some of the threshold values to minimize glaucoma progression risk in normal tension glaucoma, the diastolic BP should be greater than or equal to 65, and a diastolic BP less than 65 is linked to optic nerve hypoperfusion and increases the glaucoma progression risk. The mean ocular perfusion pressure should be more than or equal to 50, and fluctuations more than 10 millimeters and values below 50 are associated with increased visual field loss, and maintaining the mean ocular perfusion pressure greater than 50 ensures good optic nerve head perfusion. Also, the mean arterial pressure should be more than or equal to 65, and nocturnal mean arterial pressure reductions below 65 have been correlated with worsening of glaucoma, and the safe range was identified to be between 65 and 90 millimeters of mercury. And the nocturnal mean arterial pressure dip should also be less than 20%. So BP reductions of more than 20% from the daytime values should be avoided, as these overdippers, more than 20% fall in IOP at nighttime, they tend to have faster visual field progression. So what happens to the ocular perfusion pressure at night? In the supine position, mostly the intraocular pressure is on the higher side. The blood pressure goes down and hence the perfusion pressure falls. And these patients, glaucoma patients, will show a slow retinal ganglion cell death and progression of glaucoma. So while the patient is sleeping and the ophthalmologist is sleeping, but our disease, glaucoma, is certainly not sleeping at night. In fact, it is progressing at night, and nocturnal IOP is a sleeping giant. This signifies the importance of 24-hour IOP control and the use of medications which are working at night as well and having a 24-hour IOP reduction. Also, there have been studies revealing that sleeping in either the right or the left decubitus position can be harmful for that particular eye. And patients who show unilateral glaucoma progression, one should take a detailed history of head posture during sleep, whether they are constantly sleeping in either of the lateral positions. Also, if the sleep posture is face down, the eyeball is compressed against pillow, and these patients again can have progression, so they may need to use some protective eye shields to prevent the pressure on the optic nerve. Coming to obstructive sleep apnea, is there a relationship between obstructive sleep apnea and glaucoma? Obstructive sleep apnea is a sleep disorder where breathing stops or becomes shallow during sleep. And a severe OSA is when the AHI index is more than 30, and this has shown, it's found to have a high risk for glaucoma progression. So the AHI is the apnea-hypapnea index, and that tells us the number of apneic spells in 1 hour of sleep that the patient has. So less than 5 is normal, and more than 30 is a severe obstructive sleep apnea. So what is happening is there are recurrent, complete, or partial interruption of normal breathing because of the upper airway collapse during sleep, causing a decreased ocular perfusion pressure. Episodic obstructive respiratory disturbances cause severe hypoxemia and increased vascular resistance, causing compromised optic nerve head perfusion and glaucomatous optic neuropathy. So when you find patient is having controlled IOP but still progressing, and these patients, they often come back with recurrent disc hemorrhages and visual field deterioration, then such a patient, certainly you must take a sleep history of snoring or sleeping in either one of the lateral positions. Any history of being sleepy and tired during daytime, please send these patients to the pulmonologist for a sleep study. There's also a stop bang questionnaire where S is snoring, T is feeling tired in the daytime, O is if anybody has observed that the patient is stops breathing during sleep, and P is the history of being treated for high blood pressure. Bang is BMI more than 35, age over 50 years, and neck circumference more than 16 inches, and the male gender. These are high risk for OSA. So a high risk for OSA, if the score is between 5 and 8, then you are at a high risk for OSA. So these patients, if you are suspecting, then please send them for a sleep study. CPAP treatment can reduce the sleep deprivation and the oxidative stress and progression of glaucoma in such patients. But the definitive treatment is the ENT surgeon will do a uveopalato-pharyngoplasty, which will help in the OSA as well as in the glaucoma progression. So don't let your breathless night in the form of OSA be associated with blinding sight. That is the progression of NTG. A brief mention on autonomic dysregulation and glaucoma. We know that the autoregulatory mechanisms of the optic nerve is disrupted in glaucoma, and this impaired autoregulation causes the RGC death and glaucoma progression. Primary insult is at the optic nerve head in the form of raised IOP. The RGCs are working at a reduced energy states. They are more susceptible to the secondary insult in the form of the reduced ocular perfusion pressure, and along with the autonomic dysregulation, all this leads to the retinal ganglion cell death. An example of this is the Flammer syndrome, wherein you have primary vascular dysregulation. There is increased response of the blood vessels to cold and emotional stress, resulting in cold hands. And this makes the eye more sensitive to IOP spikes or blood pressure drops, and the patient is more susceptible to NTG. So we are coming back to the original question where we started. Are there any factors other than the IOP that we need to look into, and what are we going to offer to our patient next? So when we find these patients with controlled IOP progressing, we may need to reset the target IOP. Look into the compliance. Maybe the patient is not compliant, skipping drops, or not putting the drops properly, or putting all the drops together, and they're all flowing out and not getting a chance to act. Repeat a gonioscopy. You may be missing angle closure. Definitely check for the corneal thickness, and also a good diurnal variation round the clock 24-hour with a BP monitoring if possible. That will give you a good idea of the nocturnal hypotension patients. Look for obstructive sleep apnea wherever you are suspecting. Also look, you may be having a neurological pathology which you're missing. Take a history of steroid intake in the form of skin ointments or inhaling steroids, and lifestyle habits needs to be explored. Excuse me. So a detailed good history is very important of refractive surgery like LASIK, which could have reduced the corneal thickness. Rule out migraine, Raynaud's, Flammer's syndrome. Check for low BP. A night dose of antihypertensive may be causing nocturnal hypotension. Any history of hemodynamic crisis and acute blood loss. And a history of snoring is important. Take a history of head down yoga postures. So Shirshasana in any of the postures where the head is lower than the heart, you have a twofold increase from baseline IOP. So this can give rise to spikes in IOP in our glaucoma patients, which may show progression, and we really don't know until we take a detailed history. Also, like I mentioned, the history of right or left-sided sleep position. Drinking too much water or any form of fluid in one go. A lot of our patients in India, early morning, they like to drink 2 or 3 liters of water. This can cause spikes in IOP. History of excessive smoking or caffeine and steroid use, and a history of wearing tight collar and tie. There was a study in the BJO way back in 2000 where they found that people who have tight collars and ties do have a spike in intraocular pressure, which can lead to glaucoma progression. And last but not the least, a history of the occupation, these trumpet blowers who are using high resistance wind instruments, they are found to have spikes in intraocular pressure while they are using the instrument. And a good detailed examination, a repeat gonioscopy, corneal thickness, to check for pseudoexfoliation or pigment dispersion, disc hemorrhages, and the type of field defect. So you may be having a neurological field defect like seen here, and you need to definitely subject this patient to a neuroimaging. So when do you do neuroimaging? If you have a young patient with unilateral disease, optic disc pallor more than cupping, clinical findings not correlating with the visual field changes, visual field defects not typical of glaucoma like here, when it's respecting the vertical meridian, then you're thinking of neurological causes, or when there is an acute drop in visual acuity, or if the patient has color vision deficiency, then you may think of neurological causes. A detailed systemic evaluation to rule out diabetes, blood pressure, dyslipidemia, cardiovascular disease, any disease requiring long-term steroids. A carotid Doppler may be required in unilateral cases. A sleep study wherever you're suspecting OSA. And an ambulatory blood pressure monitoring, a 24-hour BP monitoring is also very beneficial to pick up the drop and the low IOP, low blood pressure. And an evaluation when you're suspecting migraine or any of those vasospastic diseases. So certain lifestyle changes for glaucoma patients. These patients need to have a good, healthy lifestyle. So regular exercise, which could be walking or jogging or swimming. Have a balanced diet, and herbal supplements like ginkgo biloba extract has been proven to show some antioxidant and neuroprotective properties. And including antioxidants and omega-3 fatty acids in your diet, and quit smoking, avoid headstands, avoid too much caffeine or alcohol, avoid too much water in one go, and weight management, avoid obesity, otherwise you're prone to other lifestyle diseases and obstructive sleep apnea. Stress management, of course, is most important for your overall healthy lifestyle, and stress will increase your endogenous cortisol and again cause a glaucoma progression. A brief mention on meditation and pranayam. So in these patients who are progressing, there's nothing much that we can offer them, and meditation and pranayam has been shown to help with autonomic dysfunction. So slow breathing exercises wherein less than 6 breaths per minute for 5 minutes in a day, at least 3 times, that is the 3-6-5 breathing, is known to help with autonomic dysfunction. And meditation, it lowers the stress and IOP and diurnal fluctuations in IOP. And mindfulness meditation is a good adjunctive therapy in advanced glaucoma. Small practical tips: repeat the VFA if you're in doubt of progression. Check for compliance. Check IOP in supine position in our office hours. That could give you a good clue of what the nocturnal IOP may be like. Measure ocular perfusion pressure in those with controlled IOP and still progressing. Skip the night dose of antihypertensive if the diastolic blood pressure is less than 65. and avoid topical beta blockers if already on systemic beta blockers. And controlling IOP is the mainstay in glaucoma management, but in those patients who are progressing, in spite of a good IOP control, do look into the vascular factors. A detailed history can sometimes be extremely helpful. And when things are not matching and not correlating, then dig deeper and find those nocturnal dippers. Thank you so much.
Thank you very much, Dr. Ritu, for a very excellent presentation, very comprehensive.
Thank you.
So we now invite Dr. Sean, who is an alumnus of Goa Medical College and Arvind Eye Hospital, Madurai. He is presently the cornea consultant and medical director at ASG Hospital, Goa. So looking forward to hear from Dr. Sean.
Thank you very much, Dr. Girish, and thank you for my colleagues in the audience. I just thought I'll cover up a few practical approach to management of keratoconus. Many times we do not have access to all the possible gadgets and devices available, but a few things of how the whole management of keratoconus has changed over the last 15 years. I think it was during the PG that we actually considered keratoconus as an ectatic disorder characterized by thinning and protrusion. It was invariably bilateral with asymmetric involvement, more likely to be progressive in a younger patient and less progressive in an older, and traditionally was considered non-inflammatory in the textbook definition, but however the concepts have now changed to consider it as a possible inflammatory etiology. We'll just go into the overview of the epidemiology and risk factors first. Again, prevalence varies widely in the general population. Asians have a greater prevalence. Family history can be variable. In Goa, we do not have too many patients having a family history of keratoconus, but in certain populations where marriages happen within the same community, they tend to be more common. Ocular rubbing, no doubt, has been the most important cause in cases of keratoconus. You have to look for associated signs of atopy, any ocular allergies, patients with Down syndrome, and these patients tend to rub their eyes. We've had patients with just having unilateral keratoconus where the only risk factor was eye rubbing. At the Indian subcontinent, we find cases at a younger age which progress more rapidly. Again, genetically, majority of the cases are sporadic, with family history in maybe 10% of cases in the reported literature being autosomal dominant. Autosomal recessive being more common, and first-degree family members at a higher risk. This is especially important when you're considering refractive surgery in a patient, whether there's any patient who was denied refractive surgery due to abnormal corneal topography. The SELECT study also reported a positive family history of 14%. So take a detailed history, look for the systemic findings in the patient, look for underlying connective tissue disorders, eye rubbing, abnormal retinal functions, and evaluation for atopy, hay fever, and asthma. These patients may require an reference to an allergy specialist for a complete allergen testing and even immunization if required. In the pathogenesis, we understand the degradation of corneal collagen and altered enzyme activities, increased MMP levels, and decrease in the tissue inhibitors of MMP. Increase in tears, a lot of tear studies which were published and even presented in the previous talk. And this reinforces that there is some inflammatory mechanism happening over there. Currently, we do not have any drugs targeting these interleukins and the other factors, but eye rubbing associated with interleukin-1, and in most patients I do tell them, please write no eye rubbing and stick it on the mirror every day so you remember not to rub their eyes, especially in children. The early diagnostic signs, here I'm presenting a 15-year-old girl who presented with just a slight change in her cylindrical power, 2015. Compared to her earlier 2014 records, we saw a bump in the cylindrical power on refraction. She was not improving to 6/6, and history of recurrent adenoids since childhood. We went ahead and did a topography, and we did find in the sagittal maps having an increased steepening in the superior areas, as well as an early bump on the Berlin-Ambrosio display. So a high index of suspicion is most important, especially it's very unusual for a person having a cylindrical power to be jumping at every visit. A non-orthogonal astigmatism on topography, vision not improving to 6/6, a significant change in the cylinder over the last 6 months, and history of associated ocular allergy can be always emphasized. The early diagnostic signs can be picked up with a very good refraction as a scissoring reflex on retinoscopy. Look for a retroillumination, the oil drop sign, and of course the Vogt's triad and the Fleischer's ring. Having even a basic anterior maps with the placido disc device like the CVK can also pick up the abnormality in the anterior curvature. You have various indices related to that. The OpScan was the first device combining the placido disc with the slit lamp image, and this provided good maps of the posterior float of the cornea as well as a global pachymetry. However, the Pentacam changed the entire aspect of evaluation of keratoconus. The anterior segment tomographic device, which had a slit image rotating in the central cornea, providing a better representation of the central cornea with evaluation of more than 25,000 true elevation points. The entire principle was based on Schumflug's principle, which describes the optical properties involved in photography of objects when the plane is not parallel to the film of the camera. Theodor Schumflug was a Swiss Army person, and he identified that in these images, if you want to take a proper image, especially if you're analyzing a corneal image on a slit beam, you need a camera which can actually evaluate even objects beyond focus, and this was a Schumflug principle, where the image plane, lens plane, and subject plane are not parallel to each other, and they intersect at the Schumflug intersection line. This is what's being used in most of the movie cameras for film shooting. The advantages of a OpScan were numerous, with limbus to limbus measurement, better representation of the center, and more accurate representation of the posterior surface. The red flags were the asymmetry, 47.2 and above keratometry, inferior temporal thinning, and changes on the anterior and posterior float, which would pick up early keratoconus. This was further analyzed by Michael Berlin and Dr. Renato Ambrosio, who devised the Berlin-Ambrosio maps. And here the goal was to combine the elevation-based data and the pachymetry in an inclusive display, which was more sensitive in detecting the ectatic conditions. Here in the anterior maps, identifying a focal bump by subtracting the central thinning area and looking for any abrupt thinning in the progression maps. What they did was excluding 3.5 millimeters around the thinnest point in the cornea. They re-evaluated the enhanced best fit smear. And if you found a significant decrease in the BFS, indicating that the thinnest and the steepest cornea are correlating, that would pick up as a yellow or a red zone in your central maps for the anterior and posterior floats. With the progression indices, evaluating the cornea from the central thinnest point as you go out into the peripheral radius, 2, 4, and 6 mm zones are most important, and any deviation beyond plus or minus 2 standard deviation were considered significant. Defining disease progression was another important area where coefficient of repeatability is very important, and most of the devices we have, you cannot compare an OpScan to a Pentacam or a Pentacam to a Galili. In moderate to severe keratoconus, you may have a difference of even 1.5 to 2 diopters, even in the same patient, just taken 10 minutes apart. So looking at these data over a period of time, 6 monthly reviews, annual review subsequently, and then only you can actually label a patient as progression. Repeatability-wise, the Pentacam and Sirius were better than those with the Galili and the other topographic devices. Looking at treatment modalities, the quality of vision in keratoconus is quite poor, and although a patient may be reading 6/12 on a BCVA, they do see a lot of starbursts, and in addition to defocus, vertical coma is the most common high-order aberrations they have. In these patients, it's definitely viable to suggest at least a contact lens trial, although some of them may be hesitant initially. Using a good RGP or a Rosquet contact lens would give a better quality of vision. For halting progression of the disease, cross-linking is the way forward, and in most patients, for better visual outcomes, however, if patients are not happy with spectacles, contact lenses provide an option. Do you have shape modulation in the form of Intax and TCAT as cares as well? And then finally, corneal transplantation in cases which do not have any further improvement. Toric ICL and toric IOL may not be FDA approved, and may be the only option in cases with diagnosed cataract or in cases where you want to debulk the refractive error. Cross-linking halts the progression of the disease. Right from the initial treatment protocols, they are indicated for progressive keratoconus at any age, even an age below 15 years. Now protocols have improved the safety of the procedure. Corneal pachymetry would be ideal to be more than 400, but however now thinner cornea protocols are there. You have to evaluate the corneal endothelium if possible, and minimum corneal curvature less than 40. Poor results are in patients with a younger age of presentation, associated eye allergy, a corneal pachymetry less than 400 microns, bilateral disease or inability to follow up, and significant change in spectacles or BCVA in the last 6 months. The exclusion criteria earlier was corneal thickness below 400, but however now almost up to 320 thickness corneal cross-linking has been done. Rule out any previous herpetic keratitis, central scarring already there, severe dry eye, a concurrent infection, autoimmune disease, and pregnant and nursing women. Here are the protocols initially established using ultraviolet A with a wavelength of 365 to 370 nanometers. With a better safety profile with the earlier protocols, even corneas lesser than 400 microns do not show any endothelial damage, and they found to be quite safe. Epithelial removal has found to have a better penetration of riboflavin in the stroma, and hence these corneas cross-link much better. Always check with your cross-linking machine the output energy, evaluate the distance of the UVA from the cornea, avoid too much of drying of the cornea or any possibility of secondary infection. And with the earlier protocol, a 30-minute treatment profile for 3 milliwatts per square meters was used. The side effects, you have to watch for microbial keratitis, especially in the first 4 days till the epithelialization is done. With most of the treatment protocols we follow now is 9 milliwatts per centimeter square for 10 minutes. TCAT treatment with cross-linking for keratoconus in patients who want a better uncorrected visual acuity allows for a limited ablation of 50 microns of the cornea. Aim is to regularize the cornea, improving the quality of vision and possibly improving the contact lens fit as well. It is not meant to give a complete refractive correction. The cases are mild to moderate keratoconus, a thinnest pachymetry more than 450 microns, and patients who are poor contact lens fits or unhappy with glasses. Rule out any allergic eye disease, ocular inflammation, or central scarring in the cornea. After removing the corneal epithelium in an 8 mm zone, the TCAT is performed at the optic zone diameter of 5.5 to 6.5 millimeters, and the maximum ablation is around 40 to 50 microns at the apex. The Athens protocol involved a PTK first, followed by a topo-guided PRK, MMC application for 30 seconds, followed by cross-linking. Combining cross-linking with photorefractive keratectomy provided improved in the uncorrected and best corrected visual acuity, and your case selection is very important in these patients. In contact lens fitting, I think Rose-K and RGP lenses are the most preferred in patients with keratoconus. Advanced keratoconus may require scleral lenses. DALC is the treatment of choice when you're considering keratoplasty in patients who are unamenable to any of the earlier techniques. DALC has an advantage to preserve the host endothelium and lesser endothelial loss, lesser chances of endothelial rejection. When it comes to penetrating keratoplasty, the indications have reduced now unless you have a very bad centrally scarred cornea. Even in a post-hydrops patient, you can start by doing a DALC procedure, and then if you have a large perforation, you can convert to PK. Although PK, keratoconus is the ideal indication with a long-term graft survival. However, the number of cases which require keratoplasty have diminished over the years. So in summary, we are looking at young individuals presenting with a very subtle onset of the disease, inflammatory markers, role of eye rubbing. A high index of suspicion is important. Try to pick up the early clinical signs and do a corneal topography wherever possible. To arrest progression, cross-linking is a well-established procedure. There's a lot of literature now on shape stabilization, and that requires a little more learning on which cases and how to do it. And finally, for visual correction, you have the Rose-K contact lenses. Thank you very much for patient listening.
Thank you, Dr. Sean, for an excellent presentation on keratoconus and its management. Nicely covered. And now we have Dr. Girish Velis. He's our next speaker. He's an alumnus also like me from KEM Hospital, Bombay. Then he went on to do a retina fellowship from Arvind Eye Hospital, and now currently a vitreoretinal surgeon in Goa.
Yeah.
Dr. Girish.
So, basically, as a clinician, we are well equipped with examining the patients and diagnosing and treating their problems. But when it comes to explaining the conditions and telling about the treatment and all, sometimes there are many challenges which we face in day-to-day practice despite a good treatment also. So a picture speaks more than 1,000 words is like this. When pictures are circulated in the WhatsApp university, social media, and some of the conditions which are already explained to the patient previously, but because of sometimes a VIP or pseudo VIP syndrome, they are taken in a different manner in the media. So the reasons are many a times whenever we are explaining about the conditions, sometimes there is no clarity about the particular disease when we are explaining the patient. The lack of clear communication before the surgery or during the surgery, or sometimes the surgery can be slightly eventful. So it is important to have a clear communication. There might be a failure to diagnose a particular case also. Improper chair time, explaining about a serious condition or a particular condition. During a busy OPD or in a high volume setup, sometimes some things can be missed and sometimes may not be properly addressed also. From the patient point of view, what happens, they are always going to compare either with their with the first operation for the second eye surgery, or from their own neighborhood, or from the relatives and all that. Sometimes they have some high expectations. Some of them are over demanding. Some of them expect for some guarantee and all. And sometimes some are, have that sort of pseudo VIP feeling. So such sort of patients are encountered in the, it's not just in the particular scenarios, but it can be in the general scenario in a cataract practice and extending till the refractive things also. Particularly speaking about retina, because I am a retina surgeon, so there are many conditions in retina which are like CSR, patients having floaters, dystrophy, and so many other things where proper counseling and proper explanation is very important for the proper adherence and compliance to the treatment. Some of the things may not be treatable, but it is important how we communicate and how we tell them that the condition is going to unfold in the near future, like that. So the solutions are like, yes, every patient, he has his own whims and fancies, and he is always about, he doesn't know about what is the problem and all. So he'll always be thinking that because he is able to see, why he should take the treatment and all. So sometimes it is important for us to identify a particular problem and identify a particular set of patients who are going to be certain subset of patients. So we need to explain them sometimes the urgency or sometimes the need to wait for a particular thing also. We need to give them a rough estimate about the cost, number of procedures, or sometimes a resurgery may also be required. Like in a retinal detachment surgery, we need to tell them beforehand only. If we are putting oil, we need to explain to them that there is a need for silicone oil removal also later on. Sometimes some conditions are treatable, but there are conditions which may not be treatable also, and that we need to tell them. But it's not that all the cases are like gone cases. So we need to give them a ray of hope, properly explaining the amount of visual recovery. So the communication can be a verbal by we can explain to them whenever they are with us, or sometimes through telephone counseling also. Sometimes how we are able to how we are telling the things through our body language and gesture also matters a lot. And we can give them a written informed materials or show some visualization charts which can help them in understanding the particular condition, and getting adherence to the treatment will be improved. So the basically it's like a contract between two individuals, and we are trying to explain to them so that they are able to understand the problem and they are able to take the treatment. So majority of the issues definitely needs to be explained to them so that they are able to understand the condition and able to go ahead with the treatment things. We need to be compassionate and patient to understand their problem also, and we need to listen properly. We cannot deny the fact that we need to properly take a consent and document all the things in the busy scenario also. So sometimes the counseling can be done by us also, or by the counselors hired who are properly trained in such conditions. There are advantages. Sometimes some patients expect that the doctor only should explain to them everything, right from the expectations about the surgery and till the end of the cost and all those things. Some of the patients but there is no end to the questions. Sometimes they might be asking certain questions again and again also. So sometimes the role of counselor also becomes important, that you can tell them that please, they will be explaining you rest of the details, and if you still any have doubts, I'll be able to clear the things. So it is important to explain to them regarding anatomical improvement and functional outcome. Like we can explain to them the 90% of the success may not be correlating with 100% improvement in your eye recovery, visual recovery also. So written materials for education can be given, and they can be made to understand about the particular condition, and appropriate examples which they will understand in their own language can be made. We need to properly explain to them for that much time that sometimes retinal detachment surgery can take more time, or might require again resurgery also. At the end of the things, we need to ask them that if you have any doubts, and can clarify about certain things also. It's important that all of them are addressed at the same time. Otherwise, once we have finished explaining them everything, and then suddenly they will say, no, there are 2-3 people we are waiting outside, and they are the one who are going to take the decision. So it's important to explain the guarded prognosis properly. And at the same time, it is also important to tell them that if you don't get operated, what is going to happen later on, if means whether the condition is completely going to cause you blindness, or how much percentage things are going to happen. So it's important that we are explaining them in a less busy scenario, in a this thing, and with the number of people who are going to take the decisions. So at the same time, it is important that when not to operate also, regarding certain cases we may not be having a particular experience about that particular case. The amount of risk we are able to take depending upon our expertise. Sometimes some of the cases we know that may not be doing good, and we want to take chance or something. So multiple systemic comorbidities also need to be taken into consideration, like that. So yes, there are many challenges where patients will be going for second opinion, or might be Googling, or might be taking help of other things and all. But at the same time, we need to consider all those factors and explain them about certain things. So yes, there are many times some of the patients might be already having taken some opinions at some other centers, and might be over exaggerating to us, and we need to identify such people and understand their proper behavior, and tackle accordingly and handle them accordingly, like that. So it's we cannot satisfy, I mean, everyone. Although you have explained all about their condition, although you have told them about everything, they might still be unsatisfied. A 6x6 person after a proper uneventful phaco surgery might still be cribbing about his itching and watering and all those things, which can be counseled pre-op also, or later on also, like that. So it's sometimes it may happen that you have to tell them that yes, such sort of condition you can consult another doctor. They will give you another opinion, like that. And so there are many things where you can't explain to them, but it is always important that we are trying to address their as much as questions possible, and take their things into proper consideration before you take up for surgery. So I would like to conclude the session by saying that mainly it's like we are doing our work, whatever possible, best possible from our side we should do. And ultimately the results may not be in our hands also. But if we have properly taken a consent and documented certain things, many of the mishaps can be prevented in the current scenario. Yeah, thank you very much.
Thank you, Dr. Girish, for covering all the areas of concern. I would like to thank the organizers for AIOC, APAO, and the committee members of GUA for giving us this opportunity. Thank you very much.